Hello, I'm Deborah, and I'm the author of the Babbage Parallel series, Reflections on the Decline of Belief in Science and Religion. I'm holding discussions on the topic covered in the series with notable experts, which brings me to my next guest, Dr. Lavan. Without further ado, Dr. Lavan, please do introduce.
Hi, Deborah. Thank you so much for having me on. So I'm Dr. Lavan Baskaran. I'm actually a GP partner. I'm based in South London, so run a couple of practices down in South London. I also have a private clinic up in Harley Street where I do not only general practice but actually do ADHD privately as well with a colleague of mine. I guess most of my awareness about what's going on with junior doctors and the situation of the NHS probably goes around some of the leadership roles I hold across Southwest London. So I'm a federation director. This normally means that we kind of oversee a large number of practices, normally somewhere in the range of 52 GP practices across our area, and also clinical director. So get into the day-to-day running in terms of getting physiotherapists, new staff in, new junior doctors in. So I get a hold on that. But a lot of my time now I do spend speaking for drug companies on various topics such as kidney disease and diabetes. But particularly for this subject today, I've had a good insight. I've been through the process, obviously, and I do teach medical students and junior doctors. So hopefully I can give you some insight into how it is.
Brilliant. Thank you so much. I think, first of all, it's really important to make it clear what a junior doctor is. So what is a junior doctor? What level of training do they have? What are they going on to achieve?
Yeah, good question, and it's very interesting you mention it this week because actually there was a notions that this week about changing the title of junior doctors. Part of the uncomfortableness is actually a lot of junior doctors, as it were, could be stages even up to what we call ST7, ST8. These are specialist trained doctors. These are doctors who've maybe been in the gynecological field or pediatric field. And they sometimes, with families and PhDs and MScs, they could be somewhere even in the range of, 45, 47, 49 even. I've got one colleague. So classing them as a junior doctor sometimes feels marginally inappropriate. But the range normally is anything basically below a GP partner or a consultant in a hospital. So any level below that. And of course, the starting point is as immediately as we come out of medical school. When we come out of medical school, we usually have our foundation year 1 and year 2, previously known as house officer years and senior house officer years. But there is the notion that was passed last week, and whether that would be in place, would be actually calling all of these doctors from that group I've named as resident doctors.
Right, that makes sense. So in terms of being a junior doctor, if you're moving up through the ranks, how do things change? How do your responsibilities change in terms of how much you're expected to work?
Yeah, another good question. I guess when you leave medical school, it is a bit of a shock to the system because obviously it's all about learning. You're on the wards learning during your medical school, of course, gaining the knowledge, but there isn't much responsibility. Any responsibilities with the consultant and other junior doctors. But when you start as a junior doctor or an F1 or foundation year 1 doctor, it is a massive jump. I know for me, I studied at University College London. It was I say a breeze. It was a good time. We enjoyed life. We learned. But actually, my learning in that first month or two, I was in Worthing Hospital on the south coast because I wanted to get out of London. And the learning is exponential, even within a week. I mean, you are literally responsible for, on calls where you could be the only doctor on a ward. I particularly chose to go to these coastal areas because I wanted that kind of responsibility where, I could be performing surgery with the support of another junior doctor, maybe a registrar, more senior colleague. And it was lovely because on those opportunities, you could vary. Where my wife, for example, she was actually at University College London for a foundation year doctors. But as you can imagine, in some of these top institutes in London, they have lots of levels, senior registrar, junior registrar, senior house officer. So actually, I would say, and I'm sure she would admit this, the responsibility wasn't as much because, in the theatre or on the wards, you had many layers. For someone like me, when I was doing gynecology, I was delivering babies alongside my colleague. I was doing appendectomies with this support, and this was in my first year as a doctor. So I think a lot of it's depends which area you are. But actually, over time, the worry now is, are we getting enough experience? Because of litigation, sadly, we are moving more towards the American idea where, litigation is high. We want to be safe. I think the old days of, see one, do one, that kind of approach is less likely now. And I think although the responsibility is still there, the clinical responsibility doing those operations, you're probably later. However, saying that, on the wards, we need staff. We're seriously lacking in terms of doctors now, as we know, and we can go on about this, but, the chronic underfunding from the government, the NHS, really scraping the barrel here. So as a result, we're having less and less doctors, many doctors moving to Australia. I've got very good friends of mine, Australia, Canada, Dubai, for better income, for better quality of life. And more than anything, just a bit of respect, a respect for that individual who's worked hard, wants to give up their time and efforts and family time to look after and care for people, not being respected in any way. And as a result, sadly, these doctors are leaving. So what you're finding is kind of junior doctors overworked, trying to hold the fort for many areas. And sadly, that will only lead to other doctors leaving.
That's really interesting that you say that, because I think for those who have no clinical background and no clinical experience, when you say they're not being well respected, I wonder if people would know what that means. And I wonder if you can expand a little bit on that.
Yeah, I mean, in my day, so I know when I joined as a partner here, my partnership, Dr. Ryan, Dr. Jeffcott, I would still call them doctor. And I know it sounds like a name. What difference does it make? But I think even that seniority, that respect, someone's given me a role, someone's given me a job, I should be, forever gratefully. It's going to provide income support. When I was in Worthing, and I don't think this is always the right thing, but it just shows the level and care. We used to have, elderly men walking down the road, and we would be heading off to the gym after work. And elderly men would get off the pavement onto the road to allow you to walk. Now, I'm not saying that's how the world should be, but you can see how truly respectful they were, very, very appreciative. And it's almost like a mutual respect where, of course, when we're on the wards and patients say, Doctor, do you mind if I could, of course, I'll drop everything. I won't eat my lunch. I'm happy to sit down, talk to the family, if I can reassure them. There was this lovely, symbiotic relationship. And my worry now is with the frustrations, and I feel it now in general practice. When I pick up the call or when I see a patient, and the first thing they do is, swearing at me. I've had a patient spit at me 2 weeks ago. When you're getting that kind of abuse, respectfully, even as a human being, we probably shouldn't take that. Now, I'm in a privileged position where as being a senior partner, I can kick the patient off my list, and I'm very comfortable to do that. I don't tolerate that swearing to my staff, abuse. I've just had one now. I've just told them off and kicked them off the list. We won't tolerate that behaviour. It doesn't happen in any other industry. And respectfully, my staff, as much as I give them extra leave on their birthday, extra holiday, London living wage, they still don't get enough pay. So I'm more than happy to stick up for them. But I think it's that respect has changed. You'll see some of the Eastern cultures. Sometimes when I've done work, I did some work in Africa recently. We built playgrounds and a nursery there. Went to Sri Lanka and went to Thailand. Went to the hospitals there. And, it's true respect where you could see yourself, wow, they're looking after me. I want to look after them. But that is definitely eroding when it comes to this country, sadly.
I think that's very interesting. So I wonder if to some extent that's because a lot of doctors are worked. It's difficult for them to get to everybody, and people are then pushing themselves forward. It's sort of tell the doctor you're in the most pain possible and you're in the most serious situation, and there's that fear that's rising, and as a result, it's sort of it's resulting in a social breakdown, I think, and that seems to be so clear. I also think it's very interesting that you mentioned that when you go to other countries, there is a recognition of doctors that's very different, and the abuse that's going on is becoming so prevalent. I wonder also if there are aspects of this that may come particularly from being in a developed country that expects the best, but also expects the supernatural of people who are inherently human, which is an interesting thing. And actually tying that in, we're seeing on the internet videos of people who are human, who are just young people who are being allocated jobs by the NHS often miles from any support system, maybe going to Northern Ireland when they're from London. And what is that doing to a doctor's well-being? What is it doing to their capacity to work and handle some of this abuse you're describing, some of the difficulties? How is that affecting?
100%. And Deborah, you make a very good point about this network or community idea, having, the breakdown, the social fabric being destroyed. And, we know during COVID, that certainly didn't help the situation, community centres due to the underfunding, how people used to go for religious purposes, to the temples, to the churches, to the mosque, people going to the temple and churches now it was dramatically reduced. And me being Hindu of origin, I question God and, on different occasions. But when I was growing up, I was at the temple twice a week. And it wasn't, my parents coming there wasn't always just for praying. It was actually just to be amongst your community, doing great work, even just a bit of gossip in between, just alleviating some of that stress. And what we find now, old days of patients coming to see us for, say, they come in drones for chickenpox. Chickenpox was a condition. You go and ask your neighbor, your great auntie next door, what is this? Chickenpox, crack on with life, whacking a bit of this. And now, there's no support network. People are on their own. And that's just the patient, and completely I accept that is definitely a big part of it. And which is why, a lot of the patients that we know very many years, I will entertain and listen, but then obviously the limit is there. But on the medical side, my gosh, I only recently understood about this. We teach students, but they probably don't want to tell us about it. But I had a 6 Imperial medical students recently, and they were telling me that in our day, we would work very, very hard. And granted, in my first 2 years, I did enjoy life a lot, but I knew at the end I needed to really crack on so that we could get better grades, try and publish, do that extra bit so that you could get your marks. And I think, whether that's in sport, I know it's important to take part, and I appreciate that's an important point, but you've got to achieve as well. We want the best people. We want people to excel, and you need that drive. And what's sad to hear is no matter what you do now in medical school, whether you're the top, you're the bottom, you're the middle, you could be allocated anywhere. So you could be that top person who's their passion, their drive, they've been working so hard. They want to get this top job that it's been their ambition, infectious disease at UCL, something like that. And actually they could be put in Jersey or Northern Ireland. Now, no disrespect to those areas. Jersey, I know, is a tax-free haven. I did consider it at one point. But everyone's situation is different. I could say myself, I wasn't married at the time, going to a different area and the fun of it and getting to know could work. But someone who, say they've done a degree, or say they're a bit older, they've got a couple of kids, or they're a young female who's just a little bit anxious, worried about actually the next steps. How can you be the best of yourself as a doctor, as a professional, if you don't have your protection barriers? That person you can just be there for you for a coffee, or the mother or father who's just there to give you a little bit of a hand. These are very difficult times. I don't think I would have got half as good as I could have been as a doctor if the friends I had around me in Worthing hadn't been there. Now, interesting, I went to Worthing. It was only an hour's drive away from my home, even though it's on the coast. And I had about 2-3 friends I already knew going there. So, that day after on call, or that struggle was on call, we'd have a code on our bleep to call our team to come in to help us. So we'd be in our pajamas, jump in and go. There was that camaraderie. But can you imagine someone, poor thing, that first, and I've told you how difficult that jump from medical school to work is. You're sending I say foreign in a respectful way. We don't know the area. You don't know where the nearest gym is. You don't know where the nearest coffee shop is. And suddenly you're put on call on your first day, which can happen. How do you deal with that? And how can you say after that, it's safe, it's understandable, and it's pro? If it had at least been a second level option where, look, it's not ideal, but it's Liverpool and I know some friends or family there, fine. But there's a very high chance of randomness, and I don't think this is boding well for the future.
It's really interesting, and I can understand this perspective, wanting to make sure that the talent is widespread, so that no matter where you're going for care, that's not affecting perhaps the standard of care, how likely you are to find someone who's got such an amazing talent for a certain thing. That sounds so fantastic. But at the same time, what you're saying in many respects is, can you get the best out of that person if they are in the middle of nowhere and they know exactly how to make friends in the area, or perhaps they think they're going to move again, so they think, is it even worth it? What's going on? The only thing I can almost liken it to, as I hear what you're saying, is a child who's been moved between multiple schools and stops having the ability to make strong friendships because those sort of not being very manageable. The other thing that I think is very interesting that you mentioned religious organizations like temples, gurdwaras, churches. When people have access to a wider community, often there are people in that community who they have a job. So even if no one in your family has anything to do with medicine, they might say, oh, well, there's someone at church and they're a doctor and you could go and talk to them. But if you're going to lots of different places and you don't know the local temple, you don't know the local church or mosque, who do you go to? You've then got to go on your own, maybe ask a few people. Not everyone we get with immediately. And there's this disconnect where we're not just supporting, but also completely detached and not gaining from that community. Do you think that's somewhat true?
Yeah, 100%. I mean, the flip side, I guess, would be, isn't it great, to be landed in a new place, make a name for yourself? How many friends and family have we had move abroad? I mean, my parents came in the 80s, with literally nothing, and came over and made a great life, great friends, great neighbours. But I think there was a time and a place almost. I think that was, very encouraging. When my dad, he was welcomed. The NHS was grateful for my dad's a GP. Right? The NHS was grateful for my dad to come along, offering him opportunities in hospital. He loved it. They loved it. They got along. Dad was very hardworking. The nurses needed. They hadn't seen work like ethic like this. So I can see it in being in situations. But I think now when we just, and you very nicely alluded to the point about the social fabric breaking down. Social media, everyone's on the phones. They're not communicating. You can see, in tubes in London, no one talks. Even within families, no one's talking. Restaurants, I see frequently people just on the phones, even though they're having all dinner together. And you see, we're in a place where that is the norm. So now you're getting someone who wants, okay, fine, I'm ready. I'm going to make the best of this. I'm going to come in. I'm going to go to the bars. I'm going to go to the gym. I'm going to go to the library and really try to make. But then no one else is doing it. How can you then create this? So I think, that isn't, in this day and age, I don't think it works. And I'm very fearful because I do always reflect on myself and think, if that was me, I'd try and have a good go at it. But would I genuinely say it would be the best fulfilling you? And I'm not saying socially, because remember, if socially at home things are solid, you are going to be a wonderful doctor. I know for a fact the people I had around me in Worthing, by the third month, we were flying to Morocco as a group of doctors. We went to Vegas, San Francisco. It was our doctors group. And even now, I met up with them a month ago. That's almost 20 years. And there's a 15-person turnout. We still make that, we created that bond. But if you're not in the right mind space, stressed at work, feeling a bit uncomfortable, can I ask my friend? I wasn't very good at taking arterial blood. It's a technique that you learn at med school. Wasn't very confident. I got one of my friends to actually do it for me for the first 2 weeks. And then he was like, Lavan, look, I'm going to help you now. You've got to get on with this. And now I love it. I can just do it without closing my eyes. But it was that nice support. Can you do that in this? And I think it's a real shame. And I know we'll probably talk about this, but all the other aspects about finances and funding, how it was different to our day, it all has a massive impact.
That's so interesting. And I think I've noticed this a bit with my father as well. He did max fax for a long time. When he was younger, moving around was really good fun, and he loved sort of stitching people up on a Friday night, and that was his thing. And he was quite lucky because he could open a dental surgery then when he sat down, and that makes things so much easier because then you're settled in one particular place. As you said, those who perhaps get married there in university or slightly after, it's really a very difficult situation in comparison as well. So the junior doctors themselves are often described as overworked, placed under hefty strain. What does this look like on the ground? What sort of hours are we talking? And what sort of working environment does that lead to?
So if you take it back, I look at Dad, I speak to Dad about this frequently because, when the pressures are high, I do ask him, when did things change? When did things get better? And remember, and I'm talking from a general practice point of view and also hospital, people like Dad would do these 24-hour on calls. So, people would call our home. I remember growing up, Dad would wake up, after doing a morning, afternoon, day, evening, he would, sit, have dinner, get ready to go to bed. And there'll be a call 11, 12, 1 o'clock, and he'd have to get up and go, get in the car, go and see that patient coming. And I look back and I think, look, should we be complaining? You know, those poor guys back in the day, and I'm sure Dad would have been the same for you, Deborah. But you know, in hospital it was mad. You know, weekend on calls, you were just on call the whole time if you managed to get a bit of sleep. So if I look back, you know, was it better than that? I can safely say, look, that was a really difficult time. But then on balance, you know, litigation risk, was it as high? The numbers, is the sheer volume. We have a massive population now that we're dealing with. The NHS is free. At the time when it was invented, this you know, point of care being free, the numbers were much lower. Now we're getting this situation where, you know, the demand is ridiculous, where actually, you know, you could literally wake up in the morning, and I get this frequently. You could literally wake up in the morning, see a spot on thing, and guess, yes, I want to book an appointment with a doctor. I mean, it's wonderful compared to the world. What a wonderful privilege. However, when that free system is there, it is, you know, it can lead to abuse, and we get frequent things. I have to deal with cases where people have gone into A&E and they've broken a nail. I've got patients where their wall has got fungus on it and they want us to help with fixing it. I've had one patient come in, book an appointment saying short of breath, asking for paper. So because of the fact that it's prone to abuse, I think the problem is with the sheer volume of the workload is quite impactful. And it's about processing. You know, these young kids who are now coming through, they're already in this situation where they don't have the community. We've just spoke about social media, how everything may be great in someone else's world, or we're seeing more of the sadder things. War in Gaza, war in Ukraine, that has an impact on all of us. And as a result, they've got all this kind of global effect on them. Then they're going into work. Then they're being told, actually, the money, after you tax the money, after you pay for your car park, after you pay for your food, after you pay for your accommodation, you're getting this much. So on an hourly rate, to then have the time and opportunity to maybe go on holiday at some time, maybe go to the gym to work out to feel better, maybe have some time to go for a run, you're removing all of that. So I think if you compare, yes, there was definitely a hard work ethic. There's no denying back in the old days. But I think with the increased risk of litigation, that this respect thing, which I still think is very important, because they certainly did have the respect back then, and that lack of respect, I could imagine being very deflated going to work, kind of, okay, more of this again. Patient's upset. Patient wants to see me. I've got enough to pay for, you know, the wedding, or a family who's unwell? Have I got enough to support them there? No. And when people tell me, oh, a lot of my friends have left to Australia in year 1 or year 2, I used to think it was a very selfish thing, genuinely, and I can hand on heart say this, because I was like, gosh, you know, we've invested so much, our tax money, all of us have invested, and, you know, they're going off. But you know what? Good luck to them. And, you know, it's because it is breaking. And I know for myself, you know, I'm fortunate with the practice I run. I have a good relationship with my private patients. But many a time we discuss, and, you know, I can tell you quite openly, you know, a drug company would pay me for my private time. I could work 14 hours as a GP partner, and I can earn that in about 40 minutes with a drug company, which I do. I do talks for various drug companies. My private work, I could do it in 3 hours and get the same money I get as a 14-hour. So then my wife, and probably you, Deborah, would say, gosh, Lavan, why are you doing that? Just work through, drop the kids off, do 3 hours, go home. But there is this innate bit of us that still want to hold on to this concept of NHS, this whether it's, you know, brainwashed in medical school. We want to help. I've had patients for over a decade, and you want to see this through. If there's some way something can change. But speaking to my colleagues today, my partner Kevin, I spoke to him, you know, in preparation to speaking to you today, as well as our junior doctor colleagues. And my slight worry is, have we missed that boat with the exodus of doctors that has happened? Can we train enough? And then those that we are trained, the ones that say, oh, fine, I'll do this, I'll do this, I'll do this, but then I'm going to be put in Northern Ireland, are they going to be like, well, no, I've done all of this, but I'm happy to jump ship now?
This is something that I think people hear a lot about. They don't see the internal impact of. And I think you've described so clearly so many things a lot of people wouldn't necessarily have thought out. Some of the reasons that people want to actually leave and exodus and get out of the system. I think it's really interesting that you brought up actually about, is it brainwashed in medical school? This is something that I find very interesting as well, that it seems to some extent that the greatest medic, vet, dentist, it almost doesn't matter which, the greatest one is the one that doesn't fail by giving up,
Yes.
fail by up and leave halfway through med school, the one who doesn't give up afterwards, because there is a slight stigma against the person who says, you know what, this isn't for me. And that's not considered self-analytical. It's considered a bit, oh, well, you're not very strong then.
Yeah.
And I do wonder somewhat whether the NHS can play on that mentality to get people to stay, because there is this sort of self-deprecating, I must suffer. That's exactly what it looked like. We do see it in other professions on a very low level. You might notice a famous person, for example, says, oh, I've been stalked, but that's what we have to accept. Yeah. And someone else will say, no, I'm walking away from this. This is absolutely not for me personally. I obviously personally don't feel this is good for my mental health.
Yeah.
And I think it's so interesting that you brought it up. I wonder, with regard to the hours, particularly with night shifts and switching to day, what's that like for someone, particularly when they're doing this for the first time?
Yeah, it's something that I think I have to say I was a little bit excited about, knowing there was going to be support there, because you have kind of the various levels of structure. There's this mindset you don't kind of call the consultant, which you really very much try not to. But it's an experience in itself, because remember, theoretically things are quieter because the hope is most people are asleep. But actually it gives a bit of reflection time, actually, seeing what happens at night time. Things can be, different responsibilities. I guess my concern now that we have data and research now saying, potentially up to 40% increase of cardiovascular risk doing night shifts. And this is in all aspects. I do worry a lot of my patients who are night shift workers. I can already predict what their outcomes are going to be, especially a lot of my diabetic patients. One of the questions I always ask is, are you a night shift worker? And this is with junior doctors as well. If they're in jobs, say, for example, in pediatrics or gynecology, jobs that are frequently now known, even if you're a consultant, to be on site, especially I know I have friends in gynecology who are, understandably, if there's 3 theatres going on, the consultant jumps in. There was this almost privilege of becoming a consultant when you were not going to be called, only when needed. But now it's this kind of thing where I appreciate why, but is it because of maybe the training hasn't been as extensive because they haven't been doing the extra hours that we used to traditionally have to do because of goodwill maybe? And now are the consultants that then come out to kind of junior consultants, as you were, not having had the full breadth of experience, not having done that traveling around Australia, doing a fellowship there, doing all kinds of crazy hours and then coming back. And then you get into the situation where with those night shifts, the safety aspect of it. If I now, in the day, I would always say, I'm not going to call it unless I'm desperate. And you try to build that confidence up. Now, if your confidence is low, from exactly the reasons we've been saying, that kind of outer ring support is not there, are you going to be more worried about litigation as well and be more likely to call up your seniors? And then you're kind of not saying it's a shortcut out, but the more frequently you call, frustrations from the higher levels. But also, are you then learning? Part of the learning is actually just kind of getting your hand stuck in there and getting on with it. But I think all of this is this forever increasing chronic issue that it's just seeping slowly. And all the points you mentioned, Deborah, you're literally touching on all of these very important points that may sound very subtle to the average man or woman on the street, but on a deep psyche level, I think when you take this night shift aspect compared to how it was before, I think it'd be absolutely, so scary for someone starting up. And you paint the worst picture there, say Northern Ireland, and this is no disrespect to Northern Ireland, I know it's a wonderful place, but from someone who's, from a very far away place, not much support, starting a night shift that first week, doesn't know anyone, scared whether they can call the gynecology consultant up. You put all of this into the mix, and suddenly you start to think, gosh, and remember, these are the foundation blocks of becoming that good, strong, as it were, mindset doctor. If you start the foundation poor in that first month or two, quite traumatic incidents, being, kind of maybe shouted at by the consultant for not doing so and so, missing something where maybe a patient death, it will just change your, trajectory as a junior doctor.
I'm wondering, as you say, it might be difficult for those who aren't within the field to understand. So I'm just thinking about how that will get explained. One of the things I was thinking about is if you're from Cornwall and move to Scotland and you're a woman and you get married and then you have for the time and you're up all night, all day, feeding, sorting, and baby gets taken to the first time is wailing, teething, and all of these things are happening. Maybe the gastric system is quite a bit colicky, and you are thinking, what did I do? My mother's in Cornwall, who would know just what this is, and my aunt would help. I'm going to call the doctor over everything that usually I would just say to my family, you've got this, you're okay, everything is completely fine. And I wonder if that somewhat has some bearing on what you mean, and hopefully people can understand a bit better. In terms of the mental health and well-being of an individual junior doctor, let's assume that there's a junior doctor watching now. What's your advice? Is there a way to handle this? Is there a way to at least manage symptoms of stress? So, and also what they should help for that means okay.
Yeah, I mean, well, I've been a doctor for 20 years, and I have to say, hand on heart, I probably this year, genuinely this year, only cracked this mental health, managing stress thing, as it were. And I think up until then, I was doing all things wrong, whether that's grabbing food in the wrong times, eating processed food, grabbing food on the go, sleeping late, drinking alcohol excessively, all the various things that you can do, not going to the gym, not socializing in various areas. And this is a process, but part of the process is you need the opportunity to grow and learn. There's all this knowledge available, but are you having time to read it? Are you in the right mindset to read it? If you're chronically stressed, we know our cortisol level goes up, our fight or flight response. We're more likely to gain weight. We're more likely to have poor sleep. We're more likely to have other sad incidences, increase of cardiovascular disease, increase of things like diabetes. So we are in a position of a junior doctor where you're chronically stressed, eating at wrong times, doing night shifts, not having a social fabric around you. You're literally going negative, 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 negative. And then we're expecting these junior doctors to then, maybe then provide financially. Well, no, actually, in my day, we used to have our accommodation paid for. A whole £1,000 was just paid every month of our income. How wonderful. So we had that money at least to do something with. These poor junior doctors having to pay for a car park, not having a mess. Remember the mess, the area where people socialize, that's going down. You're really creating an environment which is obviously going to be so negative. So this is not where I want to be in a position. I feel sorry for these. And I know if I had a family member, I would find it very difficult. And with that example you give of the mother, I know even when I had two kids, as a confident doctor, I would have thought, oh, look, I don't know what's going on here. This is a bit of a worry. But back then, you would have your mother or relative that would say it's all fine. So I do worry with the long term of all of these implications. But how can we manage the stress better? We can educate as the people on the other end now. I tell all my junior doctors now, setting the boundaries, social media, first thing in the morning, avoid that. Try not to look at your phone even. And try and find purpose and passion in the work. I know that sounds mad right now, but I know with my teams in my practice, we try to do that, when the patient is shouting, when you've got that 5-minute gap, 3 or 4 of you go for a walk, go for a jog at the end of the day together, create some network, sit and have lunch together, read, journal as much as you can, try and fit in the gym 2-3 times a week, have a tea or coffee together. These small things, they're not going to gain change, but they would certainly take the edge off the stress level. And then it's a shared comfort, just how when people used to fight in war, they go together, they have that camaraderie. You're not the junior doctor is not the only one. All across the country, this is an issue. It's not like in Liverpool, they get paid 10 times more than us in London. It's a chronic issue. What do we want to do? We're here to care for patients. And what I would say for a lot of junior doctors is I'm very fortunate now in the position I'm in. And I look back and I just think, look, I tried to use that opportunity to just work hard to learn the trade. I wanted to be the best doctor, see as many patients as possible, so that when it came to a situation when a patient would challenge me, I could say, well, I've actually seen it in this situation. So as tough it is, try and use that as a learning. Every day is a learning for you when you see that patient, but do reach out for help and use that support networks. And then do the usual things of sleeping well as best as you can, making sure the hours are right, exercising as you can, and even eat nutritious food where you can. I know it's expensive, but actually take a little bit of pride in that so that you're in a better mind state for your work and your family.
That's very interesting. And I actually wonder, are we entering a period of time where we're a crisis of junior doctors? because of this kind of stress?
Absolutely. I mean, I've had so many colleagues, and this is no offense to anyone. And a lot of people will say, oh, exactly like you said, this, it's badge of honor if you don't sleep, work hard all the time, or man up, and all those terms that are used. But people are genuinely struggling. I've got, as it were, strong people that you normally class as going off in terms of stress. They just can't deal with it. And as a result, and the other group is obviously the ones who I used to think were selfish, and now I've become, using the word private used to be a very negative word. Oh, I'm going privately. Oh, he's leaving the NHS. He's not. And as you know, when I introduced myself for this afternoon, I didn't start with I'm a private GP at Harley Street. I never start with that because it already taints an image of me. I tell patients I work 5 days a week for the NHS, 5 days as a partner in general practice, and then yes, I do my kind of side thing. But that's my, chip on my shoulder. That's the uncomfortableness we feel with private. And actually, good on people if they can set up privately and do well and actually have to leave the NHS. Maybe some shake-up needs to happen. Maybe it has to be where, they need to really look at the system, and is the only way by looking at numbers. The problem is we're in this middle phase now where so many doctors have left. It is, I know everyone says it's on its knees. It is, but it's kind of not quite on crisis point yet, because that goodwill is still running. No matter what anyone says and says, oh, goodwill's gone, there's still a lot of it. We are still doing extra hours, but it's going to be a little bit longer. The goodwill will just dip below where it gets dangerous, and it is getting dangerous. I've had cases of ambulances not getting within 8 minutes, and as a result, getting out 3 hours, patients dead from an MI. I've got patients who are going in to see us. They're going to get 2-week referrals for breast cancer. At 6 weeks, they're seen. It's already metastasized. Right? All these examples I can name one after the other. It's a real problem, no matter what anyone says. And if you really look at the numbers in terms of the actual doctors that are leaving, it's a true issue. And remember, they welcome you with open arms. Accommodation, swimming pool, money, all that stuff is there. So I don't fault any doctor who says, I'm going to leave now. What I'm hoping and praying, and it's probably too optimistic, whether there's a change in government this week or not. My hope is, it's a beautiful system. The NHS, when it works, if it's worked properly, is a phenomenal system. When you have people in America can't afford blood pressure tablets and therefore die of a stroke because of high blood pressure, where we can get all that done for patients, it is a wonderful place to work. It's just trying to find purpose in it, and hopefully people above just listening to these poor younger people coming through and just saying, look, we hear you. This is not nice for you. Let's try and support you to just get you to that next level where you're a confident doctor. And then, we can manage things just like in the position, I'm fortunate to be in now.
It seems very much that the NHS is those beautiful systems of anti-discrimination. Everyone, regardless of income, economic status, can get the help they need. And it's such a beautiful concept. I also wonder, as governments change over time, there's constantly a change in the system. And the fact that there is no continuity there, do you think that almost creates more problems than it solves, as opposed to getting used to one specific system and learning how to make it function?
Absolutely. I mean, I've been through various government changes. I know just before the Blair years came in, Dad says that was probably the worst time he remembers in his time. And then, Blair came into government, and whatever people say about him, good or bad, it was a massive impact for us, and especially in general practice, I could say, but also in hospital. It really, hospital waiting lists went down. A&E was within 4 hours. GPs didn't have to do weekends. You could outsource it. And there was a buzz. Everyone was happy. I remember Dad actually running into work on weekends. Maybe it was not to see us, but to go into weekends to bleed patients for diabetic reviews. There were, it was financial incentive, but he was happy to give up a Saturday with his family because it was very important that he gets, hits the targets. We were proud as a practice. It was a very proud time. Now it's kind of like when we come in now, I've tried to make my institutes, my practice as a happy place. So once we enter, we as staff are high-fiving, happy. We buy food every Friday or every so often to help, and we do leave and things like, we do things together. We went to Kenya together as a bonding trip to build these playgrounds. We try to do what we can. But the bottom line is the outside world is terrible. Even today, 2 things about mental health, patients literally, one girl cutting herself, she's cut herself now, I think 27 times now. And I've referred over and over again, it's my 5th rejection from mental health services. Why someone cannot be seen when they're cutting themselves, I don't know. That's the world we're in at the moment. these poor things have to go privately now. They have to pay 750 for the first consultation, 250. This is not low money. This is not quick, easy. And I just fear that even for, when we're looked after and our kids looked after, I can't confidently say I'd be happy bringing my kids up in an NHS world like this if overtired, underpaid staff are looking after my family because they've done such a wonderful job all these years, whether that is a reality in the next few years.
Yes, it does seem very much that also creates a huge barrier for those who don't earn that kind of money. And it seems that mental health services have definitely taken the biggest hits, and it seems to be across the board, doesn't it? Really, that's happened. And one of the things that we know, particularly about health, is that when people are given the right strategies and the support from the beginning, they often, when they enter crisis again, can help themselves as opposed to having to return. Whereas there are other conditions where perhaps that's not so much the case. And if they flare up, they must go to hospital, must see a GP. But with this is something that actually potentially friends and family and those around them with the right education and support can actually manage themselves. And if it's going so long, habit, it's so much more difficult to manage. So I'm sure people can only imagine what that must be like for an individual in that position. And I thank you so much for having the conversation as well. I think it's been really, and really some of the nuance conversation instead of perhaps just buzzwords and the exciting is actually the true reality.
Oh, thank you so much. Thank you for having me. I really appreciate it.
Thank you so much.